Welcome to the Biohacking Superhuman Performance Podcast. My name is Natalie Nidham. I'm a nutritionist, a human potential and epigenetic coach, and I created this podcast to bring you the latest ways to take control of your health and longevity. We cover it all, from new technology to ancestral health practices, personalized interventions, and a very special interest of mine, peptides. Enjoy the show. Welcome back, folks. Today's episode is with a three-peat guest, I believe. Her name is Dr. Suzanne Turner, and today's topic is you do not have a Prozac deficiency. Dr. Turner is amazing. She's a wealth of information as always, and we cover a lot of different topics. So make sure that you remember, however, that everything that we discuss here is for information purposes only. If there's anything here that really resonates with you and you think you might want to try, then make sure that you connect with your doctor, medical provider. Make sure that it is the right thing for you before you jump on any kind of a new protocol, supplement, or what have you. If you're looking to connect with me, you can find me at natnidham.com or on Facebook in the Optimizing Superhuman Performance group. I appreciate you guys, and that's why I'm keeping these intros short. Enjoy the episode. Welcome to the podcast, Dr. Suzanne Turner. It is so great to see you again.
It's great to see you, Natalie. Thanks so much.
Oh my God, I've been looking forward to this forever. So Dr. Turner, if you guys don't know, has been on the podcast before. She's one of those docs I just kind of can't get enough of because she's got this incredible breadth of knowledge, not to mention an unbelievable approach. And she knows about peptides and all the things. So I don't think we'll ever run out of things to talk about. But when we were talking about what would we talk about on this episode, you blurted out this topic. And I was like, yes, that's perfect, especially these days. So I've probably said that I will have talked about the topic in the intro, but you don't have a Prozac deficiency. Sounds like it should be a book, to be honest, especially coming from a doctor. So
that's a great idea, by the way. I might steal that.
I think you should. You're not stealing it. I think it's a thing. I think that would be really interesting. So why don't we talk a little bit about why this came up for you? Really,
sure.
because this kind of popped in. I don't know if it popped into your head or it's something you've been thinking about for a while. But what of all the things we could have talked about, why this?
Well, I have one of the things that I'm passionate about is changing the way that providers practice medicine and changing the way that patients perceive the practice of medicine. If you go into your doctor's office and you tell them that you have depression, you're likely to get an antidepressant medication. Mm-hmm. And I feel like that misses the mark. I understand why that has to happen, especially in the United States medical system, the way things are run. But there are providers out there who actually will help you to figure out what's happening and the reason why you have this. And no one has a Prozac deficiency. Now, again, I'm not telling you to don't take your Prozac or stop it today or whatever your similar medication is. That's not what my intention is. But it's to realize that there may be reasons why you have this problem and the symptoms that you're experiencing that get called depression that have nothing to do with a Prozac deficiency. So those are things that can be really helpful. Prozac or other medications like it can be really helpful in the short term. And Natalie, you mentioned about the similarity between a PPI like Nexium or whatever in using that to treat someone's acute intestinal symptoms. That can certainly be helpful, but this is not the long-term solution to the problem. Mm-hmm. This is a complex and requires a doctor who will take the time to tease out all the things, and not just a doctor, maybe potentially a team of providers, including health coaches, nutritionists, et cetera, who can give a breadth of information to figure out why this is happening to you as an individual patient. So personalizing your particular care, I think, is really important. And I have seen part of the reason why this comes to me is because I see patients after patients after patients who come to me on a barrage of medications when the problem is not those medications. If we had just addressed their hormones to begin with, if we had just addressed, and I don't just mean gonadal hormones, I also mean their thyroid, their cortisol, so many others. If we had just addressed all of these things, or underlying infections to begin with, this person wouldn't be in the position where they are with 10 medications. And now you're adding the 11th one because the 10th one is causing the side effect.
Yeah.
You also run into tachyphylaxis with a lot of these medications. They give a lot of side effects, particularly sexual side effects. And we're talking about often, this is in a 20 or 25-year-old person who gets started on these medications and then continues them. And they show up in my office in their 40s saying, why do I still not feel well?
Yeah. I actually find that I'm seeing more and more people in their 20s. I mean, I was working as a nutritionist and a health coach in a CrossFit gym a number of years ago. And at the time, I was floored that almost every person I was working with in that place, and these were people in their 20s and maybe their 30s, almost all of them were on some kind of an anxiety or antidepressive medication. And it really took me aback because it just seems that it just seems like it didn't seem right. And that was before 2021 happened and 2020 happened. So let's talk a little bit about, you mentioned a few of them right then, but let's talk a little bit about what are some of the things that could be driving depression to the point where someone just can't, they just can't pick their socks up. They can't get themselves off the floor. And they finally, because it takes a while for people, don't just wake up sad one day and go to the doctor and say, I'm depressed. Like by the time they go to the doctor to say that they're suffering from, that they're depressed, they've been dealing with this they've been struggling for quite a while. So, usually. Right. So, I mean, obviously it could be life circumstances. There could be a reason why you're feeling depressed. And certainly I think maybe it's in those cases where it might be helpful to use an antidepressant while the person is undergoing some kind of therapy or coaching to kind of help them to kick out, as it were, as a temporary strategy. But there's also all the physiological reasons why they could be depressed. And maybe we could talk about some of those because they're so far ranging, right? From hormonal imbalances to gut microbiome to insomnia to like whatever the case may be. So why don't you tell us a little bit about what you've seen in your practice?
Right. So if you look at the cellular level, the things that we think of that cause depression, this is a big issue if you're talking about research related to depression. The problem is we're trying to figure out exactly how do we create a model, a rat or mouse model that looks like and is the same way as depression so that we can actually treat depression and we can do studies on things that might treat your depression. So it becomes a real problem because we sort of have an idea of what might be some of the causes, inflammation, neurotransmitter imbalance, any of the autoimmune things, creating the cytokine storms that we've talked about. If you've probably heard people have talked about in dealing with the recent virus that we've had, the pandemic we've been dealing with. And so a lot of those things can happen to the brain. So traumatic brain injury can affect those because that can be an original trigger. And then you follow that with environmental exposures or estrogen deficiency or environmental toxins, things like pesticides and herbicides. If you have a thyroid disorder for whatever reason, if you have infections that are persistent, if you have a genetic mutation, there's lots of genetics that can contribute to that being the case, especially things like a COMT mutation that's going to affect your neurotransmitter balance. All of those things can be ways we treat or we create the scenario or the symptom spectrum of depression. And so when we're talking about creating a model that's useful in a rat, for example, for how do we do this, one of the original studies was done in this learned helplessness behavior where they just shock the rat over and over and over again until it just lays there and stops trying to. It's terrible, I know. But we're trying to figure out how do we figure out a model that works? Well, if that's not actually the reason that the patient has the depression in the first place, then why would we think that the treatment that works for that would work for this patient? Because that's not the original problem. And so That certainly is the case for lots of people. And there are things that happen, childhood traumas that are debilitating and really destroy your hippocampal function, so that you just don't have the ability it goes into that adrenal fatigue type thing where they're just not producing ACTH. They don't have the ability. They're Addisonian. That's certainly a possible way, but it's not necessarily the only way that we get this. So your microbiome has a big play in this, because it's the biggest source of serotonin in your body. The way that your microbiome handles the food that you eat, like tryptophan, affects the way that your microbiome will then begin to create indoles. Some of them are good, some of them are bad, based on what your microbiome is doing. We know that even 3 days of antibiotics can affect your microbiome. We know that 3 minutes after a traumatic brain injury, your microbiome is affected. So lots of things will affect your microbiome, and that will begin to affect your brain. So the indoles that are created by the metabolism of tryptophan in your intestines by your microbiome will then go to the brain and bind to aryl hydrocarbon receptors, which then creates this inflammatory storm that goes on in the brain. And inflammation is expressed in people often as depression. Wow. So there's a whole cascade of things that can go on, and it's just because your gut bugs are misaligned. And that can be from things like having a colonoscopy prep. It can
I've always wondered about that. It's interesting.
Yeah.
I remember having a client way back who was going in for colonoscopy, and it's like they strip the inside of your colon, right? And I was like, well, coming out of that, we should probably give you some probiotics and prebiotics. And I remember at the time I was working with a clinic and a doctor, and she looked at me and she's like, that's the most ridiculous thing I ever heard. I've never heard of such a thing. And I looked at her and I'm like, but you just made that person like evacuate every single thing that ever lived in their microbiome. I mean, obviously it will repopulate over time, but it seems to me we could probably give it a little boost. I don't know.
Well, and think about that when you're treating your patients with a detox. Yeah. You also want to think about that you probably are changing their microbiome, and is that the best choice for them?
Yeah. Well, it's we won't talk about this long, but one of the rabbit holes, and I fall into rabbit holes quite often, as you know.
Always.
I think we all do. I've redefined shiny object syndrome as I'm a perpetual learner, lifelong learner. Yes. That's my new definition. But I'm working with a guy who wrote this really interesting book called The Immunity Code. I don't know if you've ever heard of Joel Green. No. I think you would be so interested by it, because his entire approach, and it's about fat loss, but it's about the immune system. And it's all about the gut. And the first thing he has people do is to repopulate. Like Akkermansia is a gut bug that is severely depleted in most people. So he starts you off eating apple peels, followed by HMOs, followed by red polyphenols. And this whole kind of strategy that he outlines in this book that is incredibly detailed is that what we're doing is we're using food to nurture and feed and repopulate the microbiome, and not just in the lower GI, but also in the stomach, and taking care of the mucus layer and and all the way along. And it's just like this really fascinating approach. And I think he's a biochemist or something. So, I'm doing his course right now, and it kind of makes my brain hurt on some days, but it is so fascinating that it all starts with the gut, the microbiome, and the immune system.
Yes, absolutely. And the brain is very much affected by that. We have to realize that the blood-brain barrier is very susceptible to that. Yeah. And then when you talk about 20-year-olds being the ones that commonly will that I see also with these symptoms begin. The problem is a lot of them, especially the women, obviously the women are on birth control pills. Mm-hmm. So then we run into the problem of not only nutrient depletion, as you're the expert in that area. We run into nutrient depletions because of the medications that we're taking, but it also really puts women into a menopausal state. And so these young women can't understand why they have no libido, but it's because they don't have any estrogen to feel sexy. They don't have their progestins have now suppressed their testosterone. It's a mess.
It's a mess. So are you finding with young women on the birth control pill that you're having to reintroduce certain types of hormones to help to rebalance them at the same time?
So if I really can't convince them to do an alternate form of birth control, which I really try to do, I'm a big fan of the IUD. I really try to push the IUD, especially in my younger women, because it's going to last 10 years. You don't have to think about it. You don't have to remember to take it every day. We're not going to be dependent on your memory to be sure that you don't get pregnant when you don't want to get pregnant. Mm-hmm. And an IUD is more effective than having your tubes tied. I mean,
that's interesting. But now, are these copper IUDs, or is yes. Now doesn't copper itself present some challenges in some ways, or are you able to mitigate that knowing it going in?
Knowing it going in, I'm just giving them zinc.
Okay, so you're just helping to rebalance that ratio. Interesting. Yeah. Okay.
Or zinc foods.
Yeah. Well, yeah, pumpkin seeds. All right. So that's interesting. So in younger women or women who are on the birth control pill, doesn't have to be younger women, but certainly, because you were talking about yourself that you were put on birth control and spent how many years on antidepressants, not realizing that it's the birth control that was driving your depression.
And about 12 years ago, I came off of the birth control, and I just felt like I needed to come off of everything and see what my self was. And I was fine. Wow. I didn't have any depression symptoms. I had a clear mind. I didn't feel this sort of up and down stuff, even though I was still having regular cycles. It was amazing, the difference. So coming off of the birth control pills and coming off of the antidepressant medication, I had so many side effects to those, the antidepressant medications. And it was around that same time when I started studying about additional kinds of practicing medicine, alternative and functional and whatever kind of practicing medicine, and now in cellular medicine, trying to figure out what was happening in my life. And so I said, let me just get rid of anything that might be contributing to what's happening in me. And I'll be my first guinea pig. I think we all do that.
Sure.
We all, I or my husband are my first guinea pigs.
Yeah.
And so I just came off of everything. And before I got married, I had an IUD placed, and that's been super easy. I used like you said, the copper. But I think we have to realize that nutrient depletions occur with birth control pills, and they have to be replaced. And that we're not really using that. But birth control pills really are not estrogen and progesterone. And I'm amazed at how often I'm still having that conversation, even with what I consider my very educated patients in my office, because I see very well-educated patients, and they still come to me and say, but I'm on birth control. Why do I need progesterone? Yeah. And so I say, because you're taking estrogens and you're taking progestins, but you're not balancing your estrogens with progesterone. And so I really feel like if you're going to stay on this oral form of birth control, we're going to run into some problems. Your testosterone is going to be bound up by that high SHBG. And so your testosterone is going to be in the tank. So that's why you have no libido, no horny libido. Your estrogen is going to be low because you have very little real estrogens in your birth control pills. So, or estradiol. And so you're going to be somewhat estrogen depleted as well. It's this, and yet you'll be estrogen dominant, even though you're estrogen depleted. So it's this terrible, horrible world. Yes, it's this horrible place where we're putting you in menopause at 20. So of course you feel terrible. Of course you have depression. Of course you have no libido, and your partner can't understand why you're in this situation. And where was my delightful, joyful patient that I had, or partner that I had before? Yeah. So that's another place where I commonly will see people struggle. I think the third place is also hormonally related in the beginning of perimenopause, and that's 35, 40, in that early time period where we'll see them have either a high estrogen and a low progesterone where they get this irritability.
Mm-hmm.
Or we'll see the opposite where they have this, especially my athletes, will deplete themselves of quite a bit of their natural hormones because of their competition, their training, and they'll also have a depletion. So we see that sometimes in my male athletes as well as in female athletes, the depletion or changes in their hormones because of training. And that training then creates its own problem because you're talking about the oxidative stress situation of overtraining. And those patients need to be very specifically managed as far as on their training days and their non-training days and their ramp up to an event and then the day of event and then the post-event, the recovery times, and all of that needs to be addressed as related to their depression symptoms.
Yeah, it is amazing how prevalent depression is, though. So circling back, so we see hormonal imbalances. You mentioned earlier also probably undiagnosed non-clinical thyroid, like an underperforming thyroid that's not actually, they haven't quite fallen off the cliff yet. So their doctor is saying to them, your thyroid is, and this is the line, your thyroid is fine. Everything is fine. Meanwhile, they're losing their hair. Like these crazy things are happening. And again, people don't realize that depression is a symptom of an underperforming thyroid.
Exactly. And so we'll do a fairly extensive panel of thyroid labs that gives us a picture of what's happening all around. If harkening back to the SHBG before, that's part of my thyroid panel because it adjusts based on their thyroid as well. And so we look at quite a few markers of their thyroid function before we say your thyroid is normal. This is not your thyroid. But often it is, and even just a small tweak can make a difference. Sometimes it's just a matter of replacing their selenium, iodine, zinc. Sometimes if you could just get, what's really fascinating is I had a patient that I had been treating for thyroid. He was diabetic as well. And we got him to lose about 35 pounds. And we did that with some semaglutide.
Yeah.
And he was able to completely come off of his thyroid hormone. And I think it's partly because we were able to fix the thyroid function with the semaglutide. Now, you do have to walk a little bit of a fine line because of the risk of thyroid cancer. There are just GLP-1 receptors on the thyroid that I think were the reason why he was doing so much better. Some of that is his weight loss, so he didn't need as much, but he needed no thyroid hormone at all. And that was very strange. He was producing his own.
Wow, that's amazing. So it's almost like the thyroid was being suppressed by the excess weight and all whatever, and the inflammation, because we know that excess fat produces cytokines and inflammation in the body and the whole nine yards. But you mentioned the increased risk of thyroid cancer with semaglutide. Is that global, or is that in certain populations? Like,
it's just in thyroid cancer, history of thyroid cancer. So the study was done with rats, and the rats developed thyroid cancer. So there's not been a case of a human developing thyroid cancer as a result of using semaglutide or any of the GLP-1s, but that doesn't mean that it's not related. So it's just something you need to keep in mind if you're prescribing it or if you're taking it, especially if you have a personal history of thyroid cancer.
Right. And what about, I'm going to ask you this so this is completely off topic, guys, sorry, but what about, do you see pancreatitis issues with any of the GLP-1 agonists? I had a guy in one of my groups say that, I can't remember if it was semaglutide or liraglutide, but it was one of the GLP-1 agonists. And he said he believes that it caused him to develop pancreatitis. Have you seen that before? Or is there anything in the literature about that?
Yes. So there's quite a bit in the literature. It's a very small chance of happening happening. Of course, it's more likely to happen in diabetics because diabetics just generally are more likely to have pancreatitis, and alcoholics are more likely to have pancreatitis. So I would say in those two groups, just beware that you're more likely to create. Now, the nice thing about using semaglutide, I actually use semaglutide in my alcoholics on purpose because I do think it treats alcoholism. There's a couple of small studies. I think they were done with exenatide, not with semaglutide, but semaglutide is so easy to use because it's weekly. It really does help to decrease cravings for alcohol. Yeah. And I have a few patients that I've got on it who said, look, I'm just not going to be able to quit unless you do something to help me. Yeah. And so we put them on semaglutide and they have great results with that. It really keeps them, they say that they can now drink socially, have one, go home. They don't have to have 15. Yeah,
wow.
It's really nice.
And so for the pancreatitis, just going back to that, is that if let's say the person, is it possible that it's the overconsumption of sugar in the presence of the semaglutide with someone who's diabetic or pre-diabetic, but somehow they go to the sugar foods, even though they can't eat a lot of them, that may set the stage for that pancreatitis?
Yes.
Okay. Yeah.
It does upregulate. It upregulates production of insulin from the pancreas, of course. And so if your pancreas is already in that very stressed state, I like to think of it like the Herxheimer reaction.
Yeah.
So if your pancreas is already in that oxidative stress state and you add something that's going to push it a little bit harder, then I think that's what we're running into.
Interesting. So it's almost like a way to help people when we put them on these GLP-1 agonists is to say, stay away from sugar for 10,000 reasons. And now we have 10,001 reasons for you to stay away from the sugar. I mean, use other sweeteners like monk fruit or whatever the case may be, but sugar remains not your friend. Or trehalose. Yes. Trehalose, the new darling. Which I want to talk about, but I want to get back to Prozac is not your.
Yes. We have to do another podcast.
Oh yeah, that will not be a problem. Okay, so we've talked about sex hormone, thyroid, a microbiome is a gimme with depression. Obviously, traumatic brain injury is going to obviously also in many people can trigger depression as well. And then the other population of people you were saying that you really work with as well is people with CIRS, Lyme, mold, MCAS. And again, like this is a population of people, I'm going to guess, because of the inflammation, the systemic inflammation, not to mention the fact that they just feel crappy all the time, would be very prone to depression as well. Yes?
Right. Exactly. And your point is really wise about being aware that chronic illness is really a cause of depression itself. Not only the inflammatory state and the oxidative stress state, but also the fact that you can't go and do the things that you want, just like all of us are experiencing with this pandemic. Yeah. Not being able to do the things we want to do. We also have the problem that we are, these patients have the problem that they're not able to get out and do the things they want to do. They can't socialize like they want to. They can't exercise like they want to. This has really derailed their lives in many ways, especially the MCAS with the POTS kind of symptoms. That's a really rough thing to go through. And then just the fatigue is overwhelming. Yeah. So fatigue can be misinterpreted or can be interpreted as depression. Yeah. And it's not necessarily that. It's because of the illness that they're suffering, that they're dealing with. And so always we look for occult infections. That's especially if we have something that's not responding. I always forget and always have to remind myself that I need to ask about dental things because it's such a contributor. There's a lot of research about, is it porphyromonas, I believe, is the oral bug that's the common bad guy as far as, I think it's primarily in rheumatoid arthritis, but certainly anything that's going to increase blood-brain barrier leakiness is going to risk, permeability is going to risk them having problems with depression because you're creating this inflammatory storm, you're causing retraction of dendrites. And that kind of goes into a lot of the things that we can do to treat.
Let's get into some of that. Hey folks, we interrupt this podcast to bring you and to thank our newest sponsor, which is Bioptimizers. And we're in real luck because this month, Bioptimizers is launching their Black Friday deal right now during the first week of the month of November. And not only are they going to be giving you a huge discount all month long, they are also going to be giving away over $200 worth in free gifts. This is their biggest sale of the entire year. So this is the perfect time to stock up on some of their best-selling magnesium breakthrough. This is the only organic full-spectrum magnesium supplement that includes 7 unique forms of magnesium for stress relief, better sleep, all in one bottle. The truth is that most magnesium supplements fail simply because they're synthetic and they're not full spectrum. And you see, when you get all 7 critical forms of magnesium, pretty much every function in your body gets an upgrade, from your brain to your sleep, pain, inflammation, even less stress. So it's not just about the huge discount during the entire month of November. As I mentioned earlier, Bioptimizers is also offering all sorts of awesome free gifts and products worth over $200 with select purchases, as long as you use my unique code, which I'm going to get to. This is literally the best time to get the lowest prices, to stock up, and to take advantage of all the free extras you're going to get. You can only get this exclusive deal through my link, special for you listeners. You will not find this on Amazon or even the Bioptimizers website. All you have to do is go to www.magnesiumbreakthrough.com/Bionat and use code Bionat to get your discount and free gifts today. One last thing before I go. You should know that all Bioptimizer supplements are really the best in class. But if for some reason you feel differently, you can get a full refund up to a full year after your purchase, no questions asked. So once again, the link to go to right now for this exclusive deal is www.magnesiumbreakthrough.com/Bionat. And make sure that you also use promo code Bionat, BIONAT. So do it while supplies last and don't miss the November 30th deadline. Ready, set, go. But first, let's get back to our episode. So again, I think it's like everything else, taking care of that foundation. So the nutrition, the sleep, the exposure to sunlight, exercise, and it doesn't have to be crazy exercise, just movement, right? Nutritional deficiencies, micro deficiencies, like nutrients, whatever the case may be. But once you've kind of dealt with that, what's next in your toolkit? And I know you've got something. When you said it, I was like, I've never heard of that. Oh my God. And it's a peptide. Oh my God, that's so exciting.
Yes. It's called PE2228. That's probably, it's an easy go-to for me. It's a little bit harder to find now, but it's out there. And it's available in a nasal spray, and it works by it's a spadine analog. So it works by helping patients to, helping their brain cells to, let me get my notes up here. Sorry, one second.
And what's a spadine? How do we spell spadine?
SPADEN.
All right. Spadine analog. All right.
So it's
word of the day, folks.
Yes. So spadine was the original one that was created, and this works in a very similar way that estrogen deficiency is fixed. It works in a similar way that some of the antidepressants work. Especially, it works in a similar way to a lot of the anesthetics. It works in a similar way to ketamine, but it's. So arachidonic acid goes in and stimulates this TREC1, which increases BDNF, a brain-derived neurotrophic factor.
Right.
This BDNF then increases the production of these dendrites. Yeah. So your brain cells now become very branched. They make lots of attachments, lots of associations, and you are able to come out of that depression better than you could before, because of BDNF primarily. We're upregulating BDNF with PE2228. It's just a small fragment of that spadine, the original spadine.
And it's just very targeted. And so how is it administered? Is it an intranasal or
It is intranasal.
Such a perfect route to the brain, right? Intranasal.
Yeah.
And okay, cool. So you will use that. And do you find that people need to stay on it a long time, or is it the kind of thing that once, especially because it's having this BDNF effect, which, other things do, right? We've got lion's mane, we've got all these HIIT exercises. I mean, there's different strategies to increase BDNF. This is obviously very, very targeted, but are you finding that people need to stay on this long term? Or, I mean, I'm sure it depends, because that's the normal answer. But are you finding that this is like a course of this seems to help people move
The
past?
exciting thing about this for me is it works in about 4 days. It's pretty fast. So as opposed to, as opposed to using something like a antidepressant that's going to be, you have to tell them it's going to be 3 weeks before you get a result. There's no tachyphylaxis, so they're not going to wear out. I probably see it work in about 50% of patients. So it's not the super hit in a bunch of people, but when it works great. So patients will get a good outcome. If they, and I don't use it long-term, I'm really trying to get people, my whole goal is to get you off of anything altogether. What can I get you off of? Even your supplements and nutrition, why do you need that zinc supplement? Well, I have a copper IUD. Okay, so until you can get rid of that, until birth control isn't an issue, then fine, we'll keep you on some zinc. But the
concession, fine then.
If I can get you off of things, I always want to know that there's a reason why I'm starting something, and there's a period of time I'm going to continue this. So I'm a big fan of 6 weeks. I think 6 weeks is sort of, that concept of 40 days and fasting and Lent and those sort of things. I like 40 days as a trial period. So I will usually see people back in 40 days in 6 weeks. And I'll say, okay, let's talk about where you are. What do we need to tweak? What can we start? What can we stop? We started this because how is it doing this? And then when I start things, I try to say, okay, these are the things I'm going to be looking for making a change. Where are you on a scale from 0 to 10 with your fatigue? Where are you on a scale from 0 to 10 with your tearfulness? Where are you, all of the symptoms that they described to me in the original visit? I'll say, you told me you were at a 6 before. Today, where do you think you are? And if they're not showing significant enough improvement, I'm going to make a change and do something different, where we'll backtrack and start again.
Right. So what you're saying is some people will see a result as quickly as 4 days, but you'll keep them on for about 6 weeks to give them the chance to kind of see if it's going to work for them at all, even over the long term. And then if by 6 weeks nothing's happened, it's probably time to move on to the next thing.
Yes.
Okay, cool. That's awesome. And then I was asking you also about Semax and selank, and you were explaining that. And actually, now that I think of it, that makes sense. Those are more appropriate for as an anxiolytics. So for anxiety versus depression. And I guess if we were to distinguish them, depression is kind of this, like the poor rat who got shocked till he gave up.
Yes.
This kind of, I can't get my head up off the pillow thing. Whereas the anxiety is more of a churning kind of, almost like an upregulation of the nervous system. And
I think I think the exciting thing about using Semax and selank, and I love that you suggested those, I like the idea of using those because they do work on the inflammatory part. Mm-hmm. So we're hitting that inflammation in addition to hitting the BDNF, in addition to, we're getting a good, you're not just controlling their anxiety by hitting GABA, you're also getting some of that anti-inflammatory benefit. So I think there's some really good reasons to use Semax and selank in combination for these patients as well.
And do you use them, because I've always thought that you kind of alternate between them. Like you might use Semax for 4 weeks and then move over to selank for 4 weeks, or do you find that you use them at the same time?
I usually use them at the same time, but not on the same day.
Oh, interesting. Mm-hmm. Okay, that's interesting.
Yeah, so,
and then other cool things that we talked about were, again, CBD also, but you were talking about how you're pretty cautious around your younger crew with CBD, which I can see why,
Well, I think it's because we just don't know what it's doing yet to our epigenome.
Yeah. Yeah.
So it may not be an issue. It's kind of like all the things we're talking about right now with this pandemic. We just don't know what's going to happen going forward.
Yeah. Yeah. No, that's a long-term thing. Well, and isn't there a thing in the genomics that I did a course on genomics a couple of years ago, and the teacher at the time was talking about how in a certain population of people, they have and I can't remember what the variants are to save my life right now, but they have certain genetic variants that predisposes them to responding very poorly to CBD. And I think it was CBD, actually. It was definitely part of the endocannabinoid system. But in this, and particularly young men, like teenage men, if they overdo smoking weed, let's say, or consuming cannabinoids in excess, it can actually trigger schizophrenia in them, and which may be part of the reason why we see schizophrenia showing up in around early 20s in that young male population sometimes.
Yes. So we just don't know what it's doing for sure. So I would probably stick with the 25 plus.
Yeah. Crowd.
There's too many good choices out there. I think we also have to realize that all of this is about how do we make the cells function best. And so all of our anti-aging therapies are great for this.
Yes.
So
let's talk about those.
Yes. I mean, just basic, simple things like using CJC ipamorelin and or tesamorelin, ipamorelin, or any of those that are going to be growth hormone secretagogues. And then using things like liraglutide, even in our well patients, because of the benefits as far as cellular energy use.
Interesting. So my mom's on liraglutide. Interesting. And so how is liraglutide different than semaglutide?
I would use any of them, just a daily dose versus a weekly, any of the GLP-1s.
A daily dose, you said?
The liraglutide's daily.
Oh, I see. Whereas the semaglutide is weekly.
Yep.
Right.
Wow. They were originally designed to be used in patients with dementia to improve the energy use of the cells. And so you would imagine that they would also be effective if patients are having cellular stress that expresses itself as depression. Yeah. If we can reverse that cellular stress by giving them growth hormone secretagogues and something that would optimize their energy production, in addition, like the GLP-1s, I think that's a good 1-2 punch.
Yeah, that's amazing. So how young would you use growth hormone secretagogues though?
I probably don't go under 35 unless I see them and they are depleted.
And would you do that? Would you see that through like lower, like IGF-1 levels that are just on the floor kind of thing?
Right. And I'm going to have a much tighter, especially anybody that's, I would never think about under 21. Those people I'm going to refer to, I have a very sweet little kid who is a 21q deletion patient, but because of the legality in the United States, it's not worth the risk of my license in the United States to do that. And so I sent him to an endocrinologist who did put him on, they unfortunately put him on actual growth hormone, which I think is probably fine for him. But at some point when he gets old enough, I'll flip him over to the growth hormone secretagogues and we'll see how he does.
Yeah, no, that totally makes sense. Okay. So we talked about microbiome, butyrate, and spermidine. God, that spermidine comes up almost in every podcast.
Right. Because part of the problem is trying to get
cognitive effects, right?
It's just trying to get rid of the trash. It's helping the brain. It's one of the reasons why I haven't been excited about using hydroxychloroquine is because of it's busting up that or interfering with that trash system. So if we can get with the spermidine, if we can improve the way your body gets rid of trash, when a cell is stressed, it's going to begin to accumulate proteins that are poorly folded, that are not functional. And so if that's happening, we have to have a way to remove that trash. I explain this to patients in this way. I say, if I have a trash system, if this room is a cell, the room that we are in as a patient and doctor is a cell, and I have this room full of cardboard boxes, I can still take care of you, but it's much more difficult. And so doing my functions as a cell, as a doctor, taking care of you, hearing you, being able to listen to your heart, listen to your stomach, any of the things I need to do will be much more difficult if the room is full of boxes than if the room is empty and you and I can see each other and hear each other well. And so it's the same idea. If we can get rid of the trash, if we can get the cells to slow down, stop being in panic. It's just like what we tell ourselves about meditation and yoga and prayer time. If I can take the time to slow down, think deeply, do some self observation, do some brain rest, then I'm going to be able to get back and do the job that I need to do later in the day because I've taken that time. It's the same thing with the cell. If we can allow them to go through this autophagy process where they can slow down, take a deep breath, stop doing the work of being the cell, regroup, and then get rid of the trash, then the cells can actually do the jobs they need to do and function properly. So that's what we are looking for from something like spermidine. Butyrate, on the other hand, is an alternate fuel source itself. So it has sort of two ways that it functions. And one is the acting as a fuel source itself. The other way is acting as a HDAC inhibitor. So these are the way that the DNA wraps around these coils, chromatin coils. It wraps it tightly. So now those pieces that are wrapped in that chromatin coil are unable to be translated or used. And so if we can get that DNA unwound so that we can now access that very useful DNA, now we have the ability to produce proteins that may be more useful for you, maybe more helpful moving forward. So butyrate has these two functions, both as a fuel source. If we think about it in the colon, you eat fiber, your gut bugs eat it, creates butyrate. That's the favorite fuel source for the colon cells. Everybody's happy because they get what they need. Same thing happens in the brain. It is an alternate fuel source for the brain. And so especially in our depression or dementia patients, or even our infectious toxic brain patients, if we can get them to have a way that a fuel source for the cells so that they just have the energy to get through and function, often that alone can make a difference in their functioning ability, in their depression symptoms.
Nice. So when you talk butyrate, are we talking tributyrate, or is the tributyrate going to help with the brain and the colon, or is it tributyrate for the colon and another type of butyrate for the brain?
So if I'm treating the brain, I'm probably going to use something like a ketone ester.
I was going to ask you about ketones actually, because I'm sitting here thinking, I've gotten to know Frank Yosa at Ketone Aid pretty well. And he's a great, what's amazing about Frank is he will stop at nothing to get ketones to someone who needs them.
He's the best.
Like literally he's amazing that way. Well, he's amazing in a lot of ways. He's so committed to this mission of, and it's not just this mission of selling ketones. It's actually this mission of getting research going around ketone esters so that people can understand like how they work, where they can help. And so I was actually going to ask you about ketone esters, because when we're talking about giving an alternative fuel source to the brain, helping to mitigate inflammation and all of these different things, how much of depression in some cases might be just lack of fuel, or brain cells becoming insulin resistant and not having access to glucose. And so if we can bypass that whole energy system and give them something else.
So what's curious about ketones is you can actually your cells can take those ketones, and through the pentose phosphate pathway can create NADPH, which is that master antioxidant that can convert all of your other antioxidants that have been reduced. It can convert, or have been oxidized, can convert them all to their reduced form again. Wow. And so your body, when you're under stress, can take that ketone ester and use it for that purpose. It can be rerouted. It's just brilliant how it works. And so there's so much, as you're suggesting, there's so much cellular science around ketones. There's way less clinical science. And so I'm with them. I think it's very exciting to watch what's happening. The research around using IV and rectal butyrate are also very interesting. And so I certainly use both of those modalities in my patients, depending on what they need. And it's really tailoring it to the individual patient, keeping in mind people's pockets are what they are, their wallets are what they are. And you have to tailor that to meet their needs there as well. But I definitely would consider using the ketones as far as depression patients go, because they're going to need energy to fight off the inflammatory storm that's going on, for their immune cells to fight off whatever infection might be present. If their inflammatory storm is because of traumatic brain injury, to get the recovery going. I think all of that requires an energy source, and I think ketones are a great choice. It's sort of like immediate release. What his product is sort of like an immediate release and an extended release product. Yeah. Because it has that 1,3-butanediol, you get the immediate release of the 3-hydroxy butyrate, and then you also get the 1,3-butanediol that then goes through the liver and becomes the second release. So it's this nice 1-2 punch of ketones.
Yeah, no, and he definitely, I remember reading, I think there's actually research around TBIs where if you can get ketones into these people as soon as possible, it prevents the death of the brain cells in some ways, or it mitigates it. I don't know if it prevents it completely, but it mitigates the death of the brain neurons, just again, by giving that really easy fuel source and down regulating the inflammation. And the 9 yards. The other compound that's really interesting for that is molecular hydrogen.
Yes.
As a selective antioxidant. I've seen, myself in my practice, I've seen, I had a client who had Parkinson's disease, and she would say to me that she would wake up in the morning craving the hydrogen. And it's almost like it just somehow, it gave her that little extra boost in energy. And I think part of it for her, and I think a big piece of the hydrogen is this whole selective antioxidant piece to it, where it's not an antioxidant that's going to go after everything. And yet somehow, because of the way that it works as a signaling molecule, it seems to go after the bad actors almost selectively. I mean, again, we don't really know exactly how this happens, but it's these are all exciting areas of research for sure.
Yes, absolutely.
And the cool thing I think about the ketone esters with depression is similar to what you're saying about PE 2228, is you're going to know pretty quickly if it's going to be helpful to you or not.
Right.
Like it's either going to lift the veil for you, even if it's temporary, or you got nothing kind of thing.
Right. I think I could see it being, I could see a good research study being using it in trying to get people off of their antidepressants to help with that, restarting the whole system of making your own serotonin. I could see it being valuable in treating depression symptoms as an adjunct to any other therapy that your provider might choose.
Yeah, no, I mean, I think that, and I think what's really important for people to take away from this is, it's not that antidepressants are necessarily all bad.
Yes.
I think what this discussion really is about is what else should people be looking at? What else can you be doing at the same time? What are the other alternatives to be looked at so that they don't become this kind of crutch that you kind of get stuck on?
Right.
And definitely that ends up creating its own problems.
Well, yes. And or not fixing the actual problem that's there.
Yeah. Even worse. Mm-hmm. Exactly.
Mm-hmm.
Exactly. Yeah. No, guys, you're getting a light show. I just can't get my lights right today.
I know. I look all red today.
We're going to have to create some kind of like a studio thing or something. Okay, so I'm just looking at my list here. What stones have we left unturned? We've talked about, oxytocin. Let's talk about that, because I've talked about oxytocin on the podcast with Betsy Earth as an anabolic possibly, but oxytocin also around people who are suffering with depression may be helpful as well. And the cool thing about oxytocin is it can be used as an intranasal spray as well, right?
Yes. I think in those patients, it works really well if you can get them to do it injectable. Oh. But there are some really interesting studies around it repairing hypothalamic and hippocampal function, so that you're actually getting back what you need, getting that restoration. So I would say, especially in your patients that you see are your learned helplessness patients that we talked about before, those I think would be a really great place for this, because you can see that actual repair and restoration where they're able to produce the ACTH and FSH and all the things that they need to be producing to and gonadotropin releasing hormone to be able to then go and do the things. Why does a 25-year-old have a low hormone level? That doesn't make sense to me. So we should be able to, especially for seeing, and what I see a lot, unfortunately, is patients who have had some sort of significant childhood trauma. And I don't mean a physical trauma per se, but an emotional trauma where they have carried that through until their young adulthood. And now we're trying to figure out how to get them off of their multiple antidepressants, but also to treat their metabolic dysfunctions and their neurotransmitter dysfunctions because of their original injury, the original insult. And so obviously we're working on all the things we talked about, sleep and microbiome and all of that, but then you can add that oxytocin as a specific repair to restore the function of their brain.
That's so interesting. I never thought of oxytocin as actually repairing. I always thought of it as, it helps people to feel happier. I mean, when it does. Definitely when I use it sub-Q post-workout, I don't notice so much that I feel happier, only because I also feel happy anyway.
Post-workout, right.
I mean, I feel good. But I find that I definitely get that whole head rush thing going on, and which is very short-lived, but I kind of get a bit of a head rush. And it never ceases to amaze me how, and I think I'm using, 70, 80 micrograms, maybe. And how that, like a drop of something shot in, like put into belly fat within seconds.
It's amazing.
Like that is just like it blows my mind. Like, literally. How quickly and how powerful these compounds are in our system.
I love oxytocin. I use it in a lot of patients. There's some interesting research around weight loss. So we're going off topic here, but there's some really interesting research around weight loss, and patients will use it 4 times a day before meals and bed. And I think this was an intranasal, it was a rat study. So it had to be intraperitoneal. It had to be an injectable, but they were using it 4 times a day, and they showed weight improvement in these patients. Maybe it was a human study. I'm sorry, I have to pull it up. I forget.
Okay, wait. So we're talking oxytocin for weight loss?
Yes, but it's a 4 times a day treatment, and it's a 12 milligrams, 12 international units.
12 IUs? Milligrams?
Yeah, let me see if I can find. I'll send you the study so you can put it on the show notes.
You could never inject 12 milligrams, because I can tell you that 70
units
blows my head off.
Let me see if I can I'll send you the, here it is, eating behavior and metabolism.
Okay, actually, if you would send it to me, then I'll include the link in the show notes.
Perfect, I'll do it.
So that people can go digging into it themselves. I think that's really interesting. I can think of worse ways it's just like 4 injections a day would be a pain. So.
Yeah. Have you ever had uterine cramping from using it?
No, what I have had is the need to be close to a bathroom and fast.
Oh, okay.
So I've had a couple of clients who actually were very constipated, and I've had them use oxytocin, and it works like a charm.
Oh, that's awesome. Yeah.
So it seems to have a definite effect on the smooth muscle.
Yeah. I haven't had any patients report to me the uterine cramping. That's what's talked about all the time in research and literature, but I haven't had any patients report that, because it's used for that, Pitocin is used for that. So
yeah, but what's the dosage that they use when they're
much higher? Yeah.
Like it's got to be crazy high, right? So I don't, I've never, also my uterus is, she's been resting for the last number of years.
On vacation, retired.
She's retired. So I don't know how receptive she would be to anything at this point anyway. Okay. So oxytocin, I think we've covered all the things. Is there anything we've left off that you wanted to talk about? I mean, clearly there's loads of things we could talk about.
It's always so much fun to talk to you, Natalie.
Likewise. So, Dr. Suzanne, why don't you tell people where they can find you? Because you run this amazing practice, and I kind of wish I lived close to you just so I could come to you. Tell people how they can find you, and also if you practice telemedicine and all the things.
Yes. So we are in Atlanta, Georgia. My practice is called Vine, as in Grapevine Medical Associates. I'm on Instagram and as Dr. S. Turner. I'm on YouTube as Dr. S. Cellular Medicine. That's the biggest ways, but you can reach us through our website, which is vinemedical.com. And I have several really amazing providers that I get to work alongside who really challenge me every day and keep me on my toes. And it's a real blessing to work with them. So I'm glad to be there, but it's a great practice. I love being in their company.
Amazing. And we just also to let people know that in terms of the types of patients that you deal with mostly in the practice, I mean, I'm sure you have a whole range, but because not a lot of doctors will take in people with CIRS, Lyme, mold. So these are the complex cases. And so you have room in your practice for those guys. And then on the other hand, you're also an orthopedics kind of specialist. And so you deal with the athletes and the optimization crowd as well. Yes?
Right. Yes, absolutely. And it's a nice balance to have the two because it can be a lot to deal with to help taking care of CIRS patients. They are sweet and very ill.
Yeah. No, and it's a big job for sure. And yet I'm sure that every time you get one of them to turn the corner, it's like you have to have a party of some kind or something.
Yes, it's so exciting to get one VCS screen that's normal. You're like, yes, this is the best.
Actually,
we're on the right road.
Okay, well, this has been amazing as always, Suzanne. It's always such a pleasure to speak with you. Thank you so much for agreeing to come on the show today and for sharing your wisdom. And we've already got our next episode in the works, actually, with maybe a couple of other doctors. So I think you'll be back really soon. Thank you so much.
Thank you, Natalie.
Thanks so much for joining me on this episode of the Biohacking Superhuman Performance Podcast. If you enjoyed the show, please remember to leave us a 5-star review on iTunes because that's what helps us to be heard and to be seen. If you'd like to connect with me directly, or if you'd like to leave any comments, or if you have any questions about this episode, please reach out to me directly through my website, natnidham.com. And of course, if you're not already a member of the Biohacking Superhuman Performance community on Facebook, that's where you'll find me every day. It's a short application, just answer a couple of questions and you're in and interfacing with other amazing biohackers. Thanks again, and we'll look forward to seeing you on the next episode.